Got it now. Thank you, Dr. Flano, for pointing that out to me. May it be the only thing you have to point out for me today. I'm Wayne Tuxton. I have the pleasure of being your moderator for this program. And the title of the program is Lung Cancer Screening to Treatment 2.0, a community conversation on lung cancer. And it's called 2.0 because some of you were probably here about a year ago when HEAL brought a similar program, which was obviously part one, to introduce some of the problems as far as lung disease to this community. Now, this is being brought as part of a collaboration between the 5-Star Center, the Southside Wellness Center, Amgen, and the HEAL Collaborative. We'll hear more from the 5-Star Center and HEAL Collaborative in a minute. Thankfully, we're being hosted here at the International Institute of St. Louis, and we're very happy to see so many of you come out for today's program. I want to remind you that in your pamphlets, you'll see what the agenda for the program is, and also there's a survey. There are two surveys. There's a pre-survey, and then there is a post-survey. We'd like you to fill out the pre-survey now, and at the conclusion of this program, we'll have you fill out the post-survey. We're going to try to get rid of that feedback in a moment. So please do fill that out. Also want to make mention, if you have any questions, write them down for us, because when we have the speakers present, we will have a question and answer session at the conclusion when all of the speakers have finished speaking, and we'll be able to take everyone's questions at that time. So if you have a question when you're hearing someone talk, please write it down then so you don't forget, so we can have a chance to discuss that in a little bit. So to give us welcome, let's bring up Ms. Carla Evans. She is the Executive Director of 5-Star Center Incorporated. Ms. Evans.
Okay. Oh, that's better. Good morning, everybody. I want to welcome you all to this important event. We were very happy to sponsor part one over at 5-Star Center last year, and we're happy to be a part of it this year. As he said, my name is Carla Evans. I'm the director over at 5-Star Center. We're right down the street a few blocks at Arsenal and Nebraska or Oregon. And we welcome everyone to come down and see what we're about if you have time. I want to also thank Southside and Amgen and of course HEAL for co-hosting this event. It's very, very important that we learn about how to care for ourselves and be there for others as well. Lung cancer is very important to me. I've had a few relatives pass away from it, and it's a horrible disease. So anything we can do to prevent it, anything I can do to help anyone prevent it is something I'm going to definitely try and do. A little bit about 5-Star just for a second. We are a senior center, an activity day center, Monday through Friday. We bring folks in for socialization and to just get them out of the house and make new friends. We also have a transportation program. Our bus is sitting outside. I don't know if it's still there, but we do med appointments for people over 60. So if you have a medical appointment and you want to go, you can give us a call. We'd be happy to take you. We also have a home delivered meal program where we feed about 600 people a week. And we have incontinence program and a number of other things that we are proud to do and to serve the community. So I want to welcome you again and say thank you for coming. And I'm going to turn this over to the next person. So thank you.
A couple of housekeeping matters for those of you who may or may not need to use the restroom. It is not because Dr. Flano will soon be speaking. It has nothing to do with that. But the restrooms are just out and straight down the hallway toward the glass, and then you'll turn to the left. There are some signs that are up there. I also want to welcome, in addition to those of you that are here with us now, this program is being streamed live And so again, and it will be available later on for streaming on Facebook and on the HEAL Collaborative website. So if there's some things you want to hear from this particular program, or you might want to hear some of the things that were discussed at part 1, I encourage you to go to the HEAL, that's HEAL website, and you can have a chance to take a look at those programs. Next, I'd like to bring up Mr. Manan Shaw, who's the Chief Impact Officer for HEAL Collaborative, to also give us some greetings.
Good morning, everyone. As we get started, I just want to take a moment to say thank you to the people and organizations that made today possible. A special thank you to our community partners, 5 Star Center and Southside Wellness Center. These are organizations that show up in this community each and every single day. And I also want to say thank you to Amgen for their generous support of today's programs. You can see some of their materials on the table in front of you. Please take it home. And there's more copies in the back if you need as well. When you look around this room, it's amazing to see who's here. We have patients, family members, doctors, nurses, advocates, neighbors, all here for the same reason. It's because we care about each other's health. That means something, and I'm glad that you're here today with us. Lung cancer is one of the most serious health challenges we face. But here's the good news. When it's caught early, it is much more treatable. Screening saves lives. That's not a slogan, it's a fact. And that's exactly why we're here today. HEAL Collaborative is a nonprofit organization, and our mission is simple. We help connect people to the care that they need. No matter your background, your insurance status, where you live, you deserve to know your risk, get screened, and have someone in your corner if you need treatment. We are honored to be back here for a second year in St. Louis. Today is about 3 things. Learning what you need to know about lung cancer, understanding how to get from screening to treatment without getting lost in the system, supporting one another, because no one should go through this alone. Whether you're here for yourself, a loved one, or just here to learn, your presence here matters. So St. Louis, let's make today count. Thank you.
Thank you very much, Mr. Shaw. To get things started, we have as our first speaker, Dr. Eric Flanaugh. Dr. Flanaugh is an associate professor in the Department of Medicine in Morehouse School of Medicine in Atlanta, Georgia. He is the chief and director of the Pulmonary and Critical Care and Interventional Pulmonary Medicine at Grady Hospital, and is the director of the Georgia Cancer Center Advanced Diagnostic and Interventional Pulmonary Service. He is also the director of the Lung Nodule Clinic at Grady Hospital, and I might point out from the years 2019, 2020, and 2021, he was named by Atlanta Journal as the outstanding physician in Atlanta. Dr. Flanaugh, who will be speaking to us today on understanding lung cancer, what abnormal results mean, and the next steps. I'm sorry on that.
Good. Thank you guys for coming out. Today is going to be part 2 or 2.0. On 1.0, we talked a little bit about some of the risk factors that come with lung cancer and some of the disparities that are associated with them. And on that talk, we can next slide. Oh, slide, got it. Okay, I want to give and on that talk, we're kind of talking about some of those disparities. Next slide, that focus on the health, and we're talking about health in general and the relationship between the health and the healthcare that you receive. We talked a little bit about the environmental and biology standpoints. Next slide. But what I want to talk about today, we're going to move towards health care and how that impacts and how some people are disadvantaged by that. And when I talk about health care, we're talking about the ability to be detected early, to find it early, and then move through the health care system that allows you to get towards treatment faster and make the improvements. Next. Okay. So just a brief recap. When we talk about screening, our primary goal is to find cancer before it has started causing problems. And we talked about in 1.0 some of those risk factors that would qualify somebody to get screened. Specifically, we're looking at the age, right? Because if you have an age between 50 and 80, that would be one of the qualifications. And then we look at how much somebody has smoked through their lifetime, okay? And that, what we mean by that is we talk about pack years. And if you smoke 1 pack a day for 20 years, that's 20 pack years. If you 2 packs a day for 20 years, that's 40 pack years. If somebody has smoked within their life more than 20 pack years, and they're between the age of 80 and 50, then that would be 2 criteria that met. And then the other thing would be if you smoke any time within the past 15 years. So those 3 criteria would qualify somebody to get screened, to try to detect lung cancer early. Next slide. And so when we talk about screening, our primary goal for any type of screening, whether it's breast cancer, colon cancer, prostate cancer, is to try to find it before you actually have disease, right? Or before you have symptoms, because that's the best time to get ahead of it and then gives you the best opportunities for survival. There's a couple of trials that were done, and we know that if we do a CAT scan once a year for screening, it would lower somebody who has those risk factors, their chances of dying by at least 20%, okay, over a chest X-ray. And your chances, if you follow through the screening all the way through, decreases somebody's chances of dying from lung cancer by 25%. And the reason it is that lung cancer develops silently, okay? So if anybody's ever bruised a rib or injured their lung, it hurts, right? Because in the sides of the lung, there's a bunch of nerves coming all the way down through here, right? And then if you have a lung cancer developing, one of these little spots developing one of your airways here, it makes you cough, might cough up blood. That's another late sign. In the middle of the lung, there's no nerve fibers in there. So it gets a head start, and that's why screening is important, because we want to find it before it's being made it to the edge of the lung or into the ribs, or if it's making you cough and have coughing up blood. So that's one of the primary goals of it. So who should get screened and who gets left behind? So we know, and I just told you that in the study, if you got screened, you had 25% less chance of dying of lung cancer. Now there are some populations that have even bigger benefit from getting a screening. And African Americans, if they get screened, it's a 39% less chance of dying of lung cancer. The problem is only half of people even know that screening is available for lung cancer. Screening in minority communities, if you do screening, we set up screening programs, it closes that disparity. So you don't see the difference in people getting screened late, because what happens when people get screened late is this opportunity to get to the early diagnosis decreases significantly when compared to other races. If we look here at African Americans and we look at white individuals and we look at the chance of catching it early enough to get a diagnosis, you can see that the African American population across the United States is significantly less than others. And what that translates to is that surgical treatment for cure decreases, the lack of getting any treatment at all is worse for African Americans, and the survival is worse. So the goal is get screened, find it early, get treatment early, and then that disparity, that difference in the outcomes actually improves. Next. Okay. So when we talk about screening, because I can say all I want about screening, you have to ask yourself, what exactly is an abnormal screening? So when we get the CAT scan, because that's what it is, one CAT scan, it takes about 20 minutes to get it done. You do it 1 time a year. They look at it and they'll get the results within a week from your primary care doctor, and they can give you the results and you can figure out if there's something to do about it, or we just continue on to the next year. When you get an abnormal screening, what they're looking for is a little spot. That little spot that I showed you on the last slide is an abnormal, what we call a nodule. It's a spot on the lung. That's all it is. We like to use big terms, but we really can keep it simple here, right? So a nodule is just a small spot that we see on a CT scan. 95% of what we see on a CAT scan that have an abnormal screening, they're benign, right? We don't have to worry about they're harmless. There's a few of them that can be related to infection. Okay, you can have scar tissue, because remember, everything that we breathe goes in and out of the lungs. It might cause some inflation. Sometimes it might be there 1 year, the next year it's not there. Sometimes it may have been there a long time ago, but we just happen to find it at this one time. Then there are times where it actually is something. It could be a lung cancer. It could be something that's primarily from the lung, or it could come from somewhere else. And then again, still maybe scar tissue on those others. As the physicians, we sometimes sort them into different approaches. And you might hear this say, okay, it's a solid, or it might be part of it solid, or it's just hazy on the scan. And so sometimes we might see just a little haziness there. And some of these, we follow them differently, right? So if it's solid, if it's part solid, we're going to be more aggressive on that because that means something is grown and filling in and it's starting to be attached. If it's kind of a haziness, I don't know if it's inflation, I don't know if you had a cough or bronchitis and it went away. And sometimes we just might watch this 1, 2, 3 years and just see if it's doing anything or making any change. But that's kind of the difference in how we think about it and what we're talking about. So it's important for you to know this because what we found, and this is a study we looked at, when we looked at a population, because I can tell you in our clinic, I'm in Atlanta, and I diagnose about 180 lung cancers a year. It's the 4th largest community hospital, so the community is very similar to what we have here, okay? And we looked at some of these biological and the social determinants about lung cancer disparity. And the biggest factors that we found that really holds people back from being able to get from diagnosis to cure is health literacy, right? Understanding what's going on, what the physicians are talking about, what the providers are trying to work you through, and being able to translate so it creates action amongst ourselves, right? And what we found is a lower health literacy, not understanding what's going on, despite all of the other things that we found, income, access to care, belief systems, insurance levels. All those didn't matter as much as how much the person understands. And it's not always education level, right? Because there's a difference between health literacy and education level, right? Because if I go into the mechanic and they start telling me, I know they're working on the car, I understand it, I don't know exactly what they're doing, how do they translate that to me so I can understand? And that's what we as providers need to do. And if people that are coming to see us don't understand, that's where we need to find ways to help them understand. Because when we can fix that, it makes a difference. And so now programs are starting and we should be providing plain language understanding, right? And then we're gonna help with navigators to help get through some of this process. Next. So how do we figure out, was that nodule, was that spot, is it truly a cancer or should we not be worrying about it? Next. So one of the ways that we do this is when we see an abnormal finding, we try to get them to work with one of the navigators. Okay? So patient navigators, these are trained guides. Sometimes they're nurse practitioners. They're just people that are specially trained in doing some of these. And they help with everything that patients are having trouble with getting done. It could be scheduling and transportation. It could be explaining results. And you're going to hear a little bit more about this, so I'm not going to dive deep on this. But the other component is, and this is a very, very crucial role, is getting through the system, connecting you with the right resources, but not just connecting with, but getting it done in a timely fashion to where it can make differences. And the biggest impact it has is in the low income and those home and people are housing insecurity or income insecurity, because if you add a navigator to this, they're about 4 times, almost 5 times more likely to get through this process, get through screening, to diagnosis, to treatment, than if they don't have them. These navigators and programs with navigators, it's been shown that they actually increase the success rate of patients getting what they need by about 25%. And when we think about that, that's 1 in 4 people that weren't able to get where they needed to get are able to get there. That's a huge amount. Next. Okay, so when you have an abnormal finding, that we're looking at this and we explain to you, yeah, we really need to do something about this. The next thing we got to do is you got to get tissue. Okay, click. Okay, there's 2 ways of doing this. Sometimes we can use a little camera scope and we can go into the lungs, and there's whole new ways, robotics and virtual stuff like that. So it's very low, not very invasive, right? And we can get a sample. Or the other way is sometimes they might go under a CT scan and guide a needle, small needle, and get right into it and pull some cells out and take a look at it. It's crucial to confirm because we need to, one, confirm whether or not it was an infection or a cancer, and then we get to other ideas, what type of cancer was it? And a lot of times when we talk about this, even behind the scenes, you don't see, we have these big boards and we'll pull up CT scans that have abnormal findings, and I'll sit with a surgeon and a radiation doctor and myself, and we'll all kind of go and say, okay, what's going to be the best step of this? All this goes behind the scenes so this can happen in a timely fashion. Next click. Right. So in those events where we actually do find out that this is a cancer, right? It's nothing that anybody wants to hear. It's not stuff that we like to go tell people. But the reality is once we find a cancer, our time clock starts ticking. And we need to move through the system, move through the process quickly to find out the staging and then the next steps in the treatment. Click. Okay. So everybody hears this, right? And everybody kind of hears staging. What stage am I, doc? Right? Or we'll say, or we'll come in and say, oh, you're stage, 2B or 3B. What does that mean? Okay. The very simple thing it means is how big is it and has it spread and where has it spread to? That's it. We go through all the stages 1, 2, 3, 4. It can be very different, and they have all these A, B's now. And sometimes we just make things too complicated. So I'll simplify it to you. You can have these discussions because the other way to look at it is, if we look at this, is it localized? Okay, so is it in one area of the lung? Okay, or is it regional? So is it in one area of the lung and maybe some of the lymph nodes? Or 2, is it distant and has it spread to other places? Because that also helps us understand what the likelihood of survival is under those conditions. But when we know that when we can catch cancer in the early stage, this early stage of localized disease, that about 65% of the people are still have a good survival. They're still alive in 5 years. Okay, if we catch it at the late stage, about 9%. Now, does this mean that if the doctor comes in and says, oh, you have late stage cancer, and he says 9%, he said, okay, I'm done. Why do anything about it? No, it doesn't mean that. What that means is that's just what the likelihood. You don't know if you're one of the 9% or if you're one of the 91% that aren't. So you still go through treatment. But what this is telling us is that we need to focus on finding it early. We need to get the screening done and then get through the system to get the treatment done in timely fashion. Sometimes it's tell a patient, hey, look, we found lung cancer, whatever. Say, oh, I'm gonna get a second opinion. The first second opinion they get is on Dr. Google. Don't do Dr. Google, right? And then they decide, oh, well, okay, now I'm gonna go to another doctor. And so you gotta wait another week to get the appointment, and you gotta get all your records transferred over. Then they're gonna want a repeat test, and by that time you're a month or 2 months out. And at that point in time, it's just wasted time. Once we get the diagnosis, we're on a time clock to get you through treatment and get you done. And the concern about this is when we saw lower rates of the screening, lower rates of the early detection, then most minorities and underserved communities, they're more likely to be diagnosed at later stages, and this becomes this unequitable, this health disparity problem that we have. But we do know that when we focus on these aspects of it, and we get the diagnosis done, the treatment done, the differences actually balance out. So that we don't have the disparity when we focus on our healthcare program. Next. Okay, so we confirm it's cancer. We're asking ourselves how big is it and how much has spread, and then we need to determine that. We need to answer that question. One of the things you'll hear about is a PET scan, okay? And so a PET scan uses a sugar-based dye, it helps light up things. So if we look here you have a cancer, and on the PET scan, it helps it light up. In simple terms, they give an equivalent of a sugar molecule. On every molecule of that sugar, it has a little marker on it, a little tracer. And the thought process is, well, the cancer is very active, it's gonna eat up sugar, and then they scan and they look for where that tracer is, and this is where the tracer is. If it lights up bright, there's activity going there. Still doesn't mean it's cancer, because infection and inflammation can still be eating up a lot of the sugar, but it tells you that's a target that we need to pay attention to. And what we do is we can look through the whole body, hit the next slide, and we can see, is it in one spot here, or is it in some of the lymph nodes and then different areas of the body, and that helps us to figure out what stage you're gonna be in. The issue with that is a lot of times PET scans are not available to every hospital system that's there. And so we have to look at where somebody lives. It's not specifically whether or not people can afford it or not afford it. It's does the healthcare system have what you need? And if they don't have it, we need to probably look to go somewhere where that does. And insurance, it factors in a little bit. But we do even know that sometimes the rural areas and Medicaid and Medicare slow things down in terms of getting that. But remember, and what you would advocate, if you know somebody that's going through this, or if you yourself are going through it, your hospital doesn't have what is needed, find somewhere that does have what's needed, and now you know what to ask for. Next. Cancer treatment options, just keep it in general. For the most part, if we can find it early enough, we need to get it out of the body, right? Lung cancer is very hard to treat. If you can find it where it can come out, let's have the surgeon take it out. And a lot of times people say, oh no, I don't want anybody cutting on me and doing whatever else. This is the best way. About 95% of people that have a stage 1, an early stage lung cancer, and they get it out of the body, it's about 95% of them are still alive in 5 years. So that's number one. If it's not at that point, then there's chemotherapy or radiation or a combination thereof. Okay, but now there's even newer treatments, new targeted therapies, okay, immunotherapy, and I'll talk a little bit about those in a little bit. I don't even have to, especially some of the women here. You know, men are the hardest ones to go through and get the treatment that they need, even though we know that, oh, come on, I'm standing right here. I'm standing right here. Yes, it is. And so this is a study, it looked at all of the, of both black men, white women, black women, and they looked at who's more likely to get the treatment that could cure them. Everybody's in the 90s, except black men don't. Y'all, I heard from y'all already. Something like that. But what does this tell us all? All of us in here, that tells you this is the population we need to focus on. You know somebody, we need to get them the treatment. So new treatments, and you'll hear this a lot. And if you're not hearing this, you know somebody going through this, you want to ask them about biomarker testing. Biomarker testing. And what we're doing with biomarker testing is we can actually take a little bit of that tissue that we got through either, the bronchoscope or through the needle. They look at that and they test the tissue or markers in the blood that the cancer secretes, and they find out what are the weak points. What are the weak points of this cancer that they can attack, okay? And they can do the blood, urine, the actual tissue, and they have a lot of different markers. You heard on one of the videos, the KRAS and the ALK and whatever else. All of these are important. You don't have to memorize them, but all these are important things that they're asking to see what's the weak point, next slide, of this cancer. Because if we can find where the genetic weak points are, we can target them. And specifically for cancer, they have its own few things. Some of the DNA mutations in that cancer allow the tissue to grow and thrive. Some of it allows it to build its own blood supply, and if you can cut off its blood supply, it'll help your body kill it off easier. And other parts of it will help it spread. And the reason that's important is because in the past few years, we have about 38, 39 new treatments that either help your own system fight it off or that we can target the weak points of there. And they're not as caustic. It's not as harsh on the body as it is with chemotherapy or radiation therapy. So people may take a pill once a month, once a week. They may get a shot. But it actually gives better survival. It's almost a 26 to 40% better survival, right? The problem is that a lot of underserved communities, and African Americans specifically, they're not even getting the biomarker testing that's needed to tell you what new treatments, which of the new treatments out there will work better for them with less side effects. So this is another thing we need to ask. If someone's diagnosed with lung cancer, we need to ask them, are they getting the testing on it, the biomarker testing? Next slide. Okay. So other ways that we can improve our chances of surviving from lung cancer, because we can do all the medical stuff that we need to do, okay? But there's other things that people can do at home. And they say, well, what should I do, doc? Should I eat something? Should I not eat something? Whatever else. I can tell you one of the biggest things that makes a difference, because we know the number one cause of most lung cancers is smoking. Okay? If you have lung cancer and you stop smoking, your chances of survival go up by 26%. It ain't easy, right? It ain't easy. But if you can do that, it goes up. And early stage, if you have early stage, goes up to 36%. Okay. So because it's only, not only does it's the effect of smoking and the impact it has on your body and immune system to help fight, it's also the fact that some of the products inside this tobacco smoke are making the drugs less effective. So you'll hear a lot of this, and I have to dispel this myth because I don't like it. People say, okay, well, I'll stop smoking, I'll switch to vaping, okay? It does not do any good with respect to stopping smoking or decreasing the risk of having cancer. In fact, if you switch from just vaping, from smoking to vaping, you have a 56% higher rate of developing a lung cancer. And it's twice the risk than if you just quit smoking alone. So the myth that, oh, I'm going to use this to help me quit is not actually helping you quit. And then when people use these e-cigarettes, the vape pens, they're less likely to quit using any tobacco smoke. And because all of these contain the same chemicals to aerosolize it, the same cancer-causing chemicals that will promote growth of new tumors. So that's myth. We can't do it. Vaping doesn't help you quit. It's working on a cessation program that'll get you to quit. The other thing that really impacts how well people do with this that we need to focus on is this stigma, right? This is a hidden barrier, especially for African Americans. And what the stigma about lung cancer and smoking is this, it's sort of a blame game. It's your fault. You put yourself in that position. No, it's not your fault. It's not that. But we have to realize that tobacco use, smoking, it's an addiction. And we have to recognize that. The companies knew that. They marketed it that way, right? They knew what they were doing. But when we start focusing on it like that, it creates shame, it creates guilt, self-blame. And what people do, they say, well, I really don't want to go get screened because people are going to look at me bad because I put myself in this position. Or they're going to not, if they get the diagnosis, they really don't want to discuss the diagnosis. And when we look at some of these scores to see what people feel about with respect to the stigma, African Americans have a higher score. It's almost 10 points higher because of this stigma. And what happens that because they have this fear, that black smokers have this fear, this stigma, and they don't want to discuss it. You know, what do they do? Well, I'm going to smoke, but what do? They go behind the building. They go outside and smoke by themselves, and then they isolate themselves. And it's just a process that goes on. And they have this fear of being judged. And you know what? Next slide. The tobacco companies took advantage of that, right? Because what they did is they tried to make you feel good. We go through all the years and difference of seeing this. It's like, this is what they do. This has been targeted for every one advertisement that had somebody that was not African American in it. There were 10 others that had African Americans in it. So they targeted knowing that aspect of it. Next slide. Okay, and they're even doing it now with vaping. This is a whole marketing campaign, a manual for how to target smoking or vaping within African Americans. And you'll see that the advertisements that they use are reflecting this. Okay, next slide. So, what's on the horizon? Why should we be hopeful? Okay, because we know that when we implement some of these programs, some of these changes in our healthcare system, that we actually can improve the survival for advanced cancers, those late stage cancers. Back in 2000, less than 10% survival percentage. But now we're up to over 21% for the late stages, okay? Because some of these targeted therapies, they've been big game changers, right? The biomarker testing, targeted therapies focus on, and we can get some people, we've been treating 8, 9 years, their cancer has disappeared. They came in with late stage, so it's making improvements. And then we have these equitable programs where we're using navigators. We're using our system to pull people through these programs, expanding the screening, biomarker testing, navigators, and then going out, like Amgen's doing today, coming out into the community and educating the community so they know how to move forward through this. Because health literacy decreases healthcare disparities. So, in closing, these are the factors that we can actually focus on and play a role in with respect to the healthcare, early detection, not only the healthcare system, but us through the education that we get and to go out and spread this word and move it forward to move people through the system. Take home points. When we follow these guidelines, when we have guidelines that focus on equal treatment, equal diagnosis, that a lot of these disparities and the survivals, which is what we're going for, actually become equal, right? So we can balance those out. And we know this because there are programs at 5 major cancer centers around, and they found that if we do patient tracking, if we get navigators through, that a lot of the disparities that we've seen in the past decrease and go away. Next slide. And with that, thank you. Yeah.
Thank you very much, both, for telling me to turn the microphone on. Again, what I said was, please be sure and write down your questions. For those of you who are online, please also continue to send them in. Chicago has MJ. We are fortunate to have LJ down here in St. Louis. LJ Punch is our next speaker, and Dr. Punch is a trauma surgeon, an associate professor of surgery, a scholar within the Institute for Public Health at Washington University School of Medicine, and really so much more than that, as many of you from this community already know. Dr. Punch views gun violence as a public health issue and started the nonprofit Stop the Bleed STL, a collaboration between professionals, students, and community members to raise awareness about and address trauma, injury, and violence in our communities. As part of this work, Dr. Punch has testified before the House Ways and Means Oversight Committee in Washington, D.C. And as if that is not enough, germane to today's discussion, Dr. Punch is also the director and co-founder of 314 Oasis, a climate resilience hub formed after the May 2025 tornado to respond to the extreme weather, food insecurity, toxic exposure, and trauma with community-centered, non-institutionalized care. Today, Dr. Punch is going to give us a little taste about the impact of the environment and interactions that we can take to improve community health. Dr. Punch.
Well, thank you very much for the invitation to share. How many folks do we have in the room who are native St. Louisans? Yeah, a whole bunch of us. So you have lived your life in the Mississippi River Valley, and I grew up in the Ohio River Valley, which is not far from here. I am a trauma surgeon by training, and I've been in St. Louis for a decade. And as was stated, I'm currently focused on the tremendous impact that the May 16th, 2025 tornado had. Is there anybody in the room who was either directly impacted or had friends and family directly impacted by the tornado? A bunch of you. So you know St. Louis has been through a few things, but as they say, May 16th hit different. But I want to start with a personal story. We can go to the next slide. Based on my grandmother. You can go to the next slide. So my grandmother was a plant lover. She would walk into the plant store and see the one dying plant and swear she heard something. And that would be the one plant she would buy and take it home to her nursery. And in a few months, the thing was growing and blooming and amazing. And she had this big bow window in her house that sat on the bank of the Ohio River, bay window. And my job as a kid, I lived for many years with my grandmother, was to part the blinds every morning so her plants could get bathed by the light. The blinds were yellow and the windows were tinted with this coat of thin brown that came from her years and years of smoking unfiltered Camels. Camel cigarettes were first marketed in the early 1900s, the first time a cigarette came pre-packaged, not that you had to roll yourself. And it was marketed in these boxes of 20 as a way of making smoking, which was seen at the time in many ways a positive thing. It was literally in Women's Day magazine that smoking could help stem the weight gain of pregnancy, and women were advised to smoke while they were pregnant as recent as the 1950s. But those bay window plants would bloom year after year, and my grandmother lived there in a great deal of joy. One day she was out walking her dog, a Cocker Spaniel named Peachy. And Peachy pulled the leash really hard, and my grandmother's shoulder started to hurt. She went and saw a doctor and was prescribed physical therapy for a frozen shoulder. And one day, 2 months into her physical therapy, after the session, she couldn't stand up. We literally had to have an ambulance bring her from physical therapy to home, and ended up eventually in the hospital diagnosed with a broken hip. She had her hip replaced, and soon the actual diagnosis became clear. Metastatic lung cancer throughout her bones that had caused her original frozen shoulder. Within a week, she was home on hospice, and 2 days later, she was gone. I wish I had had more time to learn from my grandmother, her great wisdom about plants. But her life represents what happens to many people who don't get the advantages of all the wonderful medicine we just heard about. But the exposures in the environment, right, that can cause lung cancer are not limited to unfiltered Camels. So I want to share a couple more things that we need to think about here in St. Louis and across the country. Next slide. So overall, lung cancer is the leading cause of cancer deaths, right? So if somebody is going to have a cancer-related death in this country, it's going to be from lung cancer. And that similarly is true in Missouri. Missouri, on the list of 50, meaning 50 is the worst, is at 47 for new diagnoses of lung cancer, right? So that means people who for the first time are diagnosed with cancer, Missouri does not do particularly well. But really, let's take a step backwards. What is lung cancer? It's part of you that gets the math test wrong. It's part of you that messes up the recipe and switches out baking soda with salt. It's the information that allows you to be you getting messed up in a way that the cells that are supposed to repeat and copy themselves with integrity somehow shift and start making copies of themselves that are not based on the right material. In Missouri, there's also a disparate experience of that lung cancer forming, those cells repeating themselves and growing out of control, 30% higher in Black folks. And often it is caused by cigarette smoke. But there are two other factors that I want to share with you about today. One is asbestos, and the other is radon. I'll take the next slide. So I'm just going to stand to the side here. Look 1 second. So first of all, what is so bad about tobacco smoke? Do you know that the lit leaves of tobacco, once they're on fire, emit over 70 or nearly 70 toxic substances? And those are substances that have the ability to tell your cells the wrong recipe, the wrong math. They literally changes the code that makes you be you, such that one cell can get the wrong recipe and repeat itself over and over and over and over again. So when we light tobacco and the smoke goes into our lungs, it literally changes the information that our cells have. Now, our body's fighting that all the time. All the time, we're getting rid of cells that flunked math, right? We are telling them, get out. Our body's own immune system is very, very powerful. But sometimes one of the cells escapes that check and balance and ends up causing cancer. Now, radon, how many of folks have heard of radon? How many folks have a radon detector where you live? Okay. So radon is a natural gas. You don't got to burn nothing for radon to show up. You don't have to do anything wrong. It comes from the earth, and the thing is, it can accumulate or build up inside a home. There's nothing you can do per se to prevent it ahead of time. It's either there or it's not. The thing is, you can't smell it, taste it. There's absolutely no evidence. There's no way. It's not even like carbon monoxide that might give you like a headache. Nothing. I once had, in that same Ohio River Valley, a childhood friend who lived in a home that was right next to the high school. And her mother developed cancer in her late 30s. And the family moved out, and another childhood friend moved into the home. 10 years later, her mother in her 40s died of cancer too. And when they went back and they evaluated, it turned out that home was massively experiencing high levels of radon. Radon in your home should be low enough that it's under a value of 2, and that 2 has a very specific unit. But even if the level is 0.5, it's the equivalent of smoking 1 cigarette a day. So the truth is, when we live inside, like not out under the air, not in a tent, not with lots of healthy airflow, we're always being exposed to a little bit of stuff that's not necessarily going to support our health, whether it's molds or other allergens, but radon. So radon also changes DNA. It changes that recipe, it changes that information, and it can have a negative effect, and it's a factor around 4% of the time. Now, who here has heard of asbestos? Okay, true or false? Asbestos is a man-made material. Is that true? It's false. It's naturally occurring. It's like silica-based material. It's in that family, I guess, of materials. It's a natural fiber, okay? It's not the same as fiberglass, but it's like it's a material made of lots of little fibers. The tiniest piece of asbestos is like a little teeny tiny sword that is small enough it can literally poke your cells. It can get down to that cell level. So it's like a little tiny sword like poking into your cell. So it is physically able to damage your DNA. So it's different from radon and different from tobacco smoke that cause more like of a chemical or an energy-based problem. It's a stab. And when asbestos gets into your lungs, the cells that are normally there to clean up, get rid of junk like dust or pollen or anything else, they can't get rid of it. It's so good at sticking around. So it also causes chronic inflammation, which is your cells constantly trying to attack it and get it away. It's like garbage cans you could never empty. And so that can definitely create a situation in which it can also contribute to lung cancer. Next slide. On May 16th, 2025, the day started out not looking like this. Did anybody remember? It was a beautiful, gorgeous, sunny day. And then it started to rain, and then the rain started moving sideways. Then it became out in the county hail. And here in the city, especially on the north side, the sky literally turned green. I can't tell you how many people say that was the weirdest part of the day. I was in the county working on my mother's property, and my wife was at home with our youngest in an apartment building that's inside the old St. Luke's Hospital, the old regional hospital on Del Mar, which was right in the path of the tornado. Our son looked outside and was very concerned with the way the wind was moving, and the next thing they knew, the power was out and they were running for the stairwell. By the time I got home, the devastation was obvious. And there was a huge piece of roofing sitting in the parking spot where the car wasn't, because I had the car with me. So we went out with our neighbors with brooms and shovels and our little wagon, and we started cleaning up the lot. And about an hour into it, we both looked at each other and said, Art, why is my chest burning? And as we looked at the materials that we were cleaning up, it became really evident that there were fibers inside that roofing that weren't just some shingles. There was fiberglass, and likely from some of the siding as well, asbestos in the air. The truth is, the day of the storm, an enormous amount of stuff got thrown into the air. Now, thankfully, all scientific estimates are that that day did not necessarily create a problem where everyone got a cancer-causing exposure to asbestos. However, the problem now is what? Demolition. There are hundreds, actually over 1,000 properties on the north side of St. Louis that are needing to be and scheduled to be demolished. And every time one of those buildings gets demolished, a certain amount of asbestos is going into the air. Now, they're doing lots of stuff, right, to mitigate that spread. But it's just to show you that even when you're doing your very best to protect yourself, there are things in your environment that can put you at risk. Next slide. This is a visual of those many, many impacted properties along the pathway of the tornado. You can see here 1,217 properties identified just by the city's process, many of which are scheduled to be demolished. Anyone living in this impact zone must educate themselves about what's going on with local demolitions so they can protect themselves. Next slide. So here's the thing. Asbestos is fine if you don't mess with it. It's when you mess with it that it causes a problem. It makes dust. And like I said, that dust is full of those shards, those knives, those spiky fibers. It can stay in the air for up to 3 days. And there can be efforts to keep the dust at a minimum, but the exposure is still potentially there. Now, there's a mask you can wear to protect yourself from those fibers, but it's not like the surgical mask like we wear in the operating room. It's not like even those masks we had to wear for COVID, you know, the N95. The only mask that is capable of stopping those teeny tiny shards of asbestos is something called a P100 mask. It's got always these pink filters on it, but it looks like a gas mask. It's not just a regular mask. The whole point being it has to completely seal the air you breathe from the air around you. Anyone who does regular construction or demolition work absolutely has to have this kind of a mask. And the guidance that the city is giving, and I'm giving you now, and to relatives that you know are next door, is to either stay inside during demolition, or if there's something making it so that you have to be exposed, consider one of these masks. Now, as far as radon, I was really glad to see some of you have a detector. And radon detectors are actually not that complicated. I actually brought one with me today. So this little tiny thing, I know you can't see it. Good news, we're only at a 0.4 right now here, and that's a very good reading, all right? I've been watching it calibrate, and it's the highest it went is 0.6. Technically speaking, you're supposed to put it at least 20 inches off the ground and not right next to a wall. But this is a really good way to estimate what's going on. You might be surprised. I wish these were cheap. They're not necessarily cheap. But if there is anybody here who has a particular concern or would like to share this with their community, I'm offering this to you today. I'm not taking this with me. So this is my gift to the conference, and whoever would like to have it, you can fight over it later. But the point is, it's not that big a deal. You don't have to not know what's going on with radon, okay? And here's the thing. If it's found to be elevated, there are ways to help. You can vent the air underneath the home out up above the roof. That's one powerful way in a home to fix that problem. And then there is an interesting program going on in St. Louis right now. It's a collaboration with Washington University. It's called Clean STL. And it's School of Engineering, social work, some other geeky scientists getting together, and they are both studying lead in the soil, but they're also putting air quality sensors across the tornado impact. Now, there's one tricky thing, because that can give us information about generic dust. It doesn't give us the detailed information about asbestos, because the only way to measure asbestos is through this very, very specific machine that magnifies thousands of times to see those little tiny knives, and you literally have to suck the air through a vacuum, smash it onto a filter, and look at it under this really strong microscope to know if it's there or not. So asbestos is best assumed. If demolition is happening, it's there. So keep your distance, wear a mask. Next slide. Since this tornado occurred, I've been working collectively with organizations, impacted residents across the tornado zone to provide essential needs, food, water, hygiene, to impacted folks, and now helping people get housed. There are so many people living in homes that are damaged. They might be getting exposed day to day to things that they can't imagine because the air in the home is not healthy. All of that can be a risk factor, especially thinking about children and their exposure. And so if you know folks who have been impacted, you can look us up at 314oasis.com. We're helping people get home again. Next slide. You know, right after the storm, a huge, beautiful tree was felled in Fountain Park. And the work that I did to respond to the tornado was centered in Fountain Park. And one day as I was near the tree, I felt drawn to it. And in particular, there was a day where they came and they cut the tree into smaller pieces. It had a 4-foot span. And the root ball was so huge they couldn't move it. And it sat in the park for an entire year. And I went and would visit the tree, and it's almost like it spoke to me. And I wonder if a little bit of my grandma is still inside me, that she could hear plants scream, but I think maybe I can hear trees cry. I think we need to take these lessons of what St. Louis has been through environmentally in this great Mississippi River Valley and really be aware and advocate for healthy air and a safe environment. You have no idea sometimes the risks that you're near, even right inside your home. So taking precautions is super important to helping you reduce the chance of lung cancer. And also, advocate. Pain that is not explained is not a reason to send people home. People need to know. So advocate for yourself and loved ones. If your shoulder hurts, if your back hurts, it's real. And that's a huge part of identifying cancer early on. Next slide. I thank you for your time, and I thank you for holding space for people to learn more about this devastating illness, and I look forward to answering questions. Thanks so much.
Thank you very much, Dr. Punch. It is amazing when we take the time to listen, what are the things that we will hear. I want to make comment, though, that I think in a little bit later, Sarah may be commenting a little bit about getting how others can get a hold of some radon detectors. So please hang around. But we will take you up on that offer, and we'll make sure if you want to see me, just bring cash. No, no, we'll find a way to equitably get this out, and I'm sure the folks will be working on that. Again, remind you, write down any questions that you may have, because I know I was writing down some questions there too. So be sure we're going to get to those. Our next speaker is Ms. Julie Spaghettis. Ms. Spaghettis is a nurse navigator with the St. Louis University Sisters of St. Mary Health, or SSM, where she is the study coordinator for the International Early Lung Cancer Action Program. To her credit, Julie doesn't just talk about things we should do when it comes to cancer, but she actually puts literally her foot to the ground to get things done. In 2024, she and her little dog, I'm not certain how much the dog was willing to participate in this, but nonetheless, she and the dog walked 30 miles as a fundraiser for the American Cancer Society. Kudos to the dog, and thank you very much. Julie's going to talk to us a little bit about lung cancer navigation programs and the comprehensive support of what the Nurse Navigator does, because we've heard a little bit about those folks, those very, very important folks earlier before. Julie, please. Thank you.
Hi, thank you so much for coming out. It's impressive because you are getting information to self-advocate for yourself, and we have to, throughout anything, advocate for ourselves. So thank you, thank you, thank you. Is that better? Okay, I am not an IT savvy individual, so because of that, my slides could not slide over. So I'm going to use my slides to talk. Okay, so I'm a nurse. I've been a nurse for 40 years. Okay, this is my teary part. I got into nursing because my grandma had cancer. Now, as you know, we love our grandparents desperately. And you remember big hugs and Hershey chocolate, and you could put as much sugar in tea as you wanted, so much that it wouldn't dissolve. So I knew when I was young, nursing is what I was going to do. So I got into nursing. Been there 40 years. Been an oncology nurse working with cancer patients for the majority of that. I went and did some management. Oh, I don't recommend it. And I am back doing what I love, taking care of patients with cancer, because I know I can make it the best possible experience. Yeah, I'm teary. Maybe I was the person to get. No, but the whole thing about navigating is making sure that you get the best possible experience you can possibly get. And that's what navigators do for you. I haven't talked about my grandma in a while. Okay, so let's chat. So you heard of the statistics about lung cancer, and here's what I want you to know. Lung cancer can be cured. Lung cancer can be cured. Lung cancer can be cured. Do not, and I know that stigma is out there, oh, I have lung cancer, I'm going to die. Oh, not if we can help it. So stage 1, 2, and 3 lung cancers can be curable. Unfortunately, stage 4, it's usually, but not always, but usually not survivable. But there's things we can do palliatively to make people as comfortable as possible. And there's immunotherapies. Dear Lord, my mom just had one this week that are doing incredible things. So if you take anything back from me, that I love my grandma. And lung cancer screening saved lives. Okay, let me find my slides now. Now I gotta. I want to thank Jessica Smith, a collaborative nurse navigator who works with me at SSM Health. And she prepared my beautiful slides, and I'm so disheartened that you don't get to see them. Okay, lung cancer, as you know, is not only a physical battle, it's also a mental. And as my colleague said earlier, you know, there's this horrible stigma. Every one of my patients with lung cancer who have smoked, all right, let's say 95, have said to me, you know, it's my fault I smoke. No, it's not. Remember Doris Day and whatever that person's name, smoking in the movies? How about those billboards? How about radio advertisements? And what about, and when a lot of people started, you know, that was the thing. And the advertisement for pregnancy, oh dear Lord, I've never heard that one, but that's deplorable. And nowadays, let's talk about what's going on. The African American community, you can't walk into a gas station without menthol signs and, you know, girls dressed up smoking cigarettes, which I don't think you're supposed to be able to do anymore, but a lot of people are doing it, which I don't think they're supposed to be. Okay, my lock went on. Okay, so if you have lungs, you can get lung cancer. That's what you need to know. Okay, cigarette smoking, we know, increases the risk. What about radon? Radon is the #1 reason non-smokers get lung cancer. So if your house hasn't been checked for radon, you need to do it. This is a lovely device. I have no idea how much it costs, but I can tell you most of us can't afford it. This is what you can afford. The state of Missouri did, unfortunately, their money's ran out, will provide a free radon detector. It's just a little flat disc. It has charcoal in it. You put it in the lowest level, non-drafty from maybe 48 hours, and then you send it back in the envelope that's provided. These screenings, and maybe every state offers these free screening tests. I can only speak to Missouri. You can find them on Amazon. Now, here's what you need to know about that. Amazon has screenings advertised for $8.99. Woo, that's a steal. No, it's not, because then they charge you $25 to $30 to process it at the lab. So if you're looking for one on Amazon, make sure it includes the test as well as the lab and get the best deal. I think I was able to find one for maybe 25 being the lowest, but look, make sure that you're not getting, you know, something pulled over your eyes with that delicious looking $8.99 one. Okay. I told you I'm non-savvy. Okay, so we know that there are disparities in healthcare. We know that the African American community is also impacted by that. We know that when we look at the American Cancer Society, African Americans are 13 less likely to be diagnosed early. So what's happening is we're finding later stage or late stage lung cancer when it's not curable. When we find it early, it's curable. Stage 1 is very curable. Stage 2 has less curability, but there's still things we can do. We know that 19% of the African American community are less likely to receive surgery. So stage 1 lung cancer surgery is the gold standard. That's what you want to have. And if you can't have it, there's a a cyber knife that's not a knife, it's beams of radiation that can provide that life-saving treatment for you. We know that 11% of African Americans are less likely to receive any treatment, and that could be for a variety of reasons. Now, one of them has to do with mistrust, mistrust of the medical community. I'm sure everyone here is in the African American community is aware of the Tuskegee trials, and probably have relatives or cousins or aunts or uncles or individuals who might have been impacted by that. So that has led to a lot of mistrust, not only then, but through the generations. And the African American community is 13% less likely to survive 5 years compared to white individuals. And that is because of a lot of barriers and misconceptions as well as trust issues. So, as one of my colleagues had mentioned earlier about the lung cancer screenings, over 14 million individuals in the United States are eligible for lung cancer screenings. The white population, I didn't write down, but it's 4.7% of that 14 million white individuals are getting screening. That's a whole lot of people that need screening that we can save lives. Unfortunately, the eligible African American individuals, 1.7% are being screened. That's not even 2% of that 14 million. That's, again, a lot of lives that we can be saving if we can reach the community, provide that education, break down any barriers, and help get screenings done. And being able to address those disparities is critical to overcoming them and getting those lung cancer screenings. So, what is a lung cancer screening? It's a low-dose CAT scan. It's a CT chest. So you go in this big, I know you can't see this, but I can show you later. It's the big donut, and you lay on a table, and the table moves inside this great big open donut. It's open, it's not small or confined, and it doesn't take, I don't think, more than 10 minutes to actually do the low-dose CT of the chest. You can also hear it referred to a low-dose lung cancer screening, low-dose lung screening, LDCT, low-dose lung cancer screening. So you might hear different names, but it all means the same thing. And again, the medical community, we like to make it challenging, clearly. Okay. What's different from a low cancer screening from, a diagnostic or the standard CT of the chest? It's the amount of radiation. I read, but I couldn't find the statistics to document it in my presentation, that it's 90% of the radiation. Don't quote me on that one, but it's significantly less. So what's the difference? So when you get a CT of the chest, a low-dose CAT scan, they take a picture of your lungs, and it's slices. So the slices aren't as clear, but they're clear, as the high-dose CT of the chest. So the high dose is a really crisp picture of the lungs and the vessels, and you can still see bones or anything associated in that range. The low dose has less radiation, so it's not as clear of a picture, but it still picks up lung nodules, masses, something larger than a lung nodule, something concerning. So it's an extremely great tool. And you might ask, well, why can't I just have a CT of the an x-ray. Well, the study that proved that lung cancer screening saved lives compared chest x-rays, a group of chest x-rays to a group of individuals getting screened at the same interval, and it proved that lung cancer screenings were superior. And x-rays can't show they don't necessarily show small nodules. They might, but the likelihood is smaller. So lung cancer screening is superior than x-rays. So you might have to change into a gown. A lot of times they'll just have you flip your necklace to your back. They might ask you to take it off. One of my hospitals, you don't even have to change in the gown. For men and women, they will just perform the screening. Quick and painless. There's no prep, nothing you have to do the day before, the day of, or afterwards. So the benefits of screening, we talked about them. We can find early stage lung cancer and cure. That's why we want to do this. And who should have a lung cancer screening? Anyone who is high risk. Okay, so who's high risk? High risk are individuals who have smoked a 20-pack year history. So 1 pack of cigarettes a day for 20 years, a half a pack of cigarettes for 40 years, or any combination of math to get you to that 20-pack year history of cigarette smoking. Only cigar smokers, at this point, they are not included. So we are looking at cigarette smokers. Okay, is this covered by my insurance? Probably. If you have CMS, Medicare, Medicaid, yes, 100%. You need a pre-auth, and you have to meet all of the CMS mandated things. That includes a doctor's appointment with a counseling shared decision-making visit that's documented in that medical record, as well as when they have to order the test with the correct ICD-10 codes. So it's a process. Medicare likes to make things fun. Now, commercial insurances, most of them will pay for a lung cancer screening. There's 2 sets of guidelines for lung cancer screening. There's the CMS or Medicare, Medicaid, and that is age 50 to 77. A current or former smoker, somebody who have quit within the last 15 years, is a former smoker. They have to be no signs or symptoms of lung cancer, so no unexplained weight loss or new worsening coughing, coughing up blood, that type of thing. Age, smoking, what'd I miss? Okay, I think that's it. Now, the difference with the U.S. Preventative Services Task Force is that if you have secondary insurance that covers, you're able to get a screening with the same with the criteria similar, except you can have them from age 50 to 80. So there's 3 additional years. Okay. And pre-authorization is required with some insurances, but not all. So I kind of need to know if your insurance needs one or not. Okay, how do you get a lung cancer screening? So CMS requires that you go to a provider, a nurse, NP, pulmonologist, and they have to see how you are, assess your smoking history. Here's what you need to know about your smoking history. please be accurate. So I can tell you that when I talk to people about their smoking histories and when doctors talk to patients about the smoking histories, sometimes they're not honest because of stigma. It's embarrassing. You know, I hate to tell somebody I started at 14. But one of the things, the honesty will help get the screenings that you need, deserve. So please be honest. That counseling shared decision-making visit needs to occur and be documented in the doctor's medical record. And I work at SSM. When we get, so our doctors that work in our institution, before a screening, we make sure that that documentation is there. If it's a non-SSM provider, when we get the order, we make them send us that documentation that has it in it, just to make sure it's done. And we provide education with non-SSM providers of what do you need to know, what do you need to do, because we don't want any patients not getting screenings, and we want it paid for as a preventative, your preventative benefits, just as a colonoscopy for all of us and mammograms for women. So they write the order and then it can be scheduled. Okay, so risk and harms of screening. I have a piece of paper back there that has those on it, but I'm just going to review a couple. So a false positive result, what does that mean? That will say that it looks highly probable you have lung cancer, but you may not. So that may lead to additional testing, biopsy, and or treatment that you didn't need, overdiagnosis. So there's this, some cancers are detected, and we know they're cancers. And through research, we know that some of these lung nodules, they call them indolent, and that means slow growing and would probably never harm a person in a lifetime because they are so slow growing. We don't know the percentage of those. We hate to assume that anything is indolent because if it comes back cancer, it's cancer. But we know that that's a phenomenon that we need to know more information about, and people are doing studies, and we will get more information. Radiation. So we know that radiation isn't good for you. And I saw you move. We're cognitively aware that of the radiation doses that you're getting, stress and anxiety. So any of those things I listed can cause stress and anxiety that impacts you. So those are things that we have to talk about, and the doctor or provider will talk to you about those. So you know, what happens after a lung cancer screening? Somebody will get back to you about those results. So at my facility, we send a letter to every individual about every lung cancer screening that you have. And it will either say that it's LRADS 1, LRADS 2, 3, or 4. And LRADS 1 and LRADS 2, we just say that you need to follow up in a year. LRADS 3 and 4, we get a letter that says you need some additional testing. So generally, your doctor's office will call you. If you haven't heard from them in 2 days, I would call them. And if you're at SSM, we send you a letter. I'm sure Siteman does the same thing. I'm sure BJC does the same thing. So, navigators. So, The navigators are here to help you through a process. When lung cancer or any cancer is diagnosed, there's generally a navigator to help with scheduling, transportation. We assess for barriers. Do you have insurance? Do you have transportation? Do you have family support? We look at a gamut. Are you able to pay your bills? Can you get heat? So we help. And socially, is your family here? Is your family supportive? Do you have friends? Do you have a church community that, you have loved ones there? It doesn't have to be your family. We all know that. So we help with that and make sure that you get the best possible care when you're diagnosed with lung cancer as you can possibly get. Okay. I'm sorry, my slides are goofy. So the best possible thing you can do, stop smoking. Stop smoking, get a lung screening if you're eligible, get a radon kit, regardless of whether you smoke or not, because we know that non-smokers with high radon levels in their house can develop lung cancer. And what about if you're in a house that you're smoking and it's high radon? That's kind of a double whammy. So get your house checked. 2 minutes. So if you live in an apartment in radon, your apartment, whoever owns it, should be checking. So check with them. Ask which building they checked. Because say there's 6 buildings, if they check building 1, well, what about the others? You want to make sure that your building is checked. What if you get lung cancer? What about support groups? There is a Lung Cancer Connection. It's here in St. Louis. It's a homegrown support group. A lady developed lung cancer, stage 1. She said, where's the support group? She went looking for one. There wasn't one. Well, she said, by golly, there's going to be one, and she started one. It's a great support group. It's for family, friends, loved ones, significant others. They help provide education, help find resources, a list of resources, and they also provide money for research, valuable research that is being done here in the St. Louis community. I think it's at WashU, maybe it's Siteman, it's one of those.
Okay, I found this on the web for research.
All right, that's it. Thank you so much.
The conclusion of our final speaker, we will have a roundtable discussion. We'll take questions and answers. Then we'll also have a chance to have a few words, and then we will have lunch. So please hang around for that. I should point out that Dr. Punch is kind enough to say that the radon detector will be going to 5-star. So that's the way they go. Yes, Carla, surprise, surprise, that's great. I'd like to bring up our next speaker, Dr. Sarah Chavez. Dr. Chavez is the Assistant Director of Community Outreach and Engagement at the Alvin J. Siteman Cancer Center, Division of Public Health Services, Washington University School of Medicine. Dr. Chavez has an eclectic background, which includes prior study in Scotland, where she worked with the team that did the original cloning of Dolly the sheep, for those of you who may remember that one. Dr. Chavez has extensive experience with AI and was recently awarded a Marion G. Horchman online teaching innovation grant for her work on leveraging AI instruction. We will either hear many different ways to cook lamb chops, or we're going to hear about the exploration of the revolution of AI tools in lung cancer care. Either way, I'm sure it's going to be interesting.
Hi, thank you so much. I'm hoping I'm loud enough. I have 6 kids, so I'm usually loud enough. So I too got into cancer because of a family connection. I lost all 4 of my grandparents to cancer. I lost my grandmother, who I'm named after, on my 15th birthday. And pretty much immediately after that, I said, I'm going to figure out what is going on here. I'm going to figure out, like, I'm going to figure this out. And so I decided I was going to be a scientist, like, pretty much right away. So when I started doing research, I really quickly realized that the work that we're doing is so important, but it always bothered me that not everybody could get it. Like, who has access to all of this great work? So that kind of is what drove me into this area. And I can tell you right now, you know, when I lost my grandma, she had a smoking related cancer. She had already survived breast cancer, and the smoking finally was what took her life. But there are so many cool things on the horizon. I don't want anyone to feel discouraged by it. So that's kind of the framework I picked for my presentation. Okay, next slide. Okay, so like any good teacher, I'm like, what can I do to learn more about what's going on? Because this field is moving so fast. So what I did is I actually used a couple of the tools I teach my students to use, and including some of the high school kids I work with. There's a really fun program you can use if you want to learn more about this. Through Notebook LM, you can actually upload the really complicated stuff that you find, all of these studies and papers, and then just ask it simple questions. So that's kind of what I recommend for people who are trying to figure out what to do, and for some of these really heavy technology areas, kind of how to get started. Next slide. So what I found is in searching this, there were actually about 50 really good new studies that are telling us what's on the horizon as far as AI goes. Okay, next slide. So these are the 4 basic areas that I think we're really going to see AI and these new technologies coming into play. The first being the ability to detect and kind of monitor those nodules that we've been talking about. So from my perspective, being in community outreach, we want to make sure people are getting their lung cancer screenings every year, because that screening and detection, we can follow that same nodule. We can make sure we're keeping a close eye on it. So we really try to make sure people return for that next appointment. We don't just want it to be a one-time thing and then we never see them again. Diagnosis is also really important. And I'll kind of get into some of the aspects that are happening around here in Missouri around the diagnosis part. But then once we move into treatment and planning, that's really where they can start to use the AI to give you better predictions about whether or not you're actually going to respond to different immunotherapies. And I'll be able to give you like a solid example of that. And then finally, the prognosis and the follow-up, because we all want to know, if you are diagnosed, like, how bad is it? What do I have to expect? And I think that's a big open area. You know, you're planning for your future. You're planning how much time you have with your family members. We want to give you the most accurate information we can. Next slide. So this is kind of where we're at right now. You know, ideally, people are getting all this biomarker testing. What really happens, though, is sometimes you're not actually getting the right amount of testing or the right type of testing. So about half of newly diagnosed patients with non-small cell lung cancer did not receive any type of biomarker testing right before COVID. And then about 30% didn't get the appropriate amount of testing. So even when we're talking about what percentage of people get biomarker testing, that doesn't mean that they actually got the right type or the full panel, like the full possibility of what they could get. Okay, next slide. So the first thing I looked into is that sort of that detection and the classification. When you look at using AI, what they're doing is they're basically feeding these images into a system and letting the AI tools supplement what the radiologist is doing. So if you opt into this, it's not like you're saying, I'm not going to get a doctor, the computer's going to diagnose me. That's not what's happening. What they're doing, though, is that they're looking at like different pixel counts. They can look at that density, that sort of fuzziness, and they can assess whether or not that nodule is more or less likely to be cancer. And when they compare that against the human results, it's so far the sensitivity, the ability to accurately diagnose is about 86%, but also the specificity. And the difference between the two is, are you going to get a false positive? Are you too sensitive and you're telling everybody they have cancer when really they're not? Or are you not sensitive enough? Is the specificity not, is that, if that's really low, it means that the bar is set higher before you get a positive diagnosis. But it's doing really, really well with these new AI tools that they have to upload your images through. Next slide. And here's kind of the image that I was able to find. What they're doing with most of these imaging technologies is they're taking that tumor and they're actually comparing it at the pixel level. And these are things that even the best radiologists, the human eye cannot detect it. So from our perspective, through the Lung Cancer Coalition, we want to make sure everyone in Missouri gets this because this is the type of scanning, the use of that technology to read people's lung cancer screening is going to be a huge difference maker in the future. It's going to make sure that the results we're giving you are super accurate and that we're detecting it as early as possible. Next slide. Okay, so the next thing, and this is something that's really important to me personally, being a molecular biologist in my training, is the biomarker testing. They can do a lot of these really cool digital pathology. So if you get diagnosed in rural Missouri and there's not a big hospital to do these types of pathology, they can create the slides, upload it somewhere, and someone else can read the slides for you. So it really does change things as far as who gets access to the biomarker testing. And the same thing with these radiology images. If they can go into the cloud to where your doctor or your radiologist doesn't have to be at the hospital next door, it's a great asset for a lot of our patients. Next slide. Okay, and then what I was mentioning about that difference maker in the additional images. So this is looking at that sort of risk stratification, like what is the chances of this, are you like a high risk tumor or a low risk tumor? And the more scans you get, the more accurate they can get. So if you're continuing to get your lung cancer screenings year over year, they're going to be able to distinguish between whether or not you're a high risk for lung cancer or a lower risk. Next slide. So this is where it gets complicated with all this biomarker testing and the genetics. They're all this alphabet soup of all these gene names that they throw at you. And we all know that, at its very heart, cancer is genetic. It's something in the DNA that is messing up. It's getting the recipe wrong. I always describe, it's like a recipe box. I have my grandma's recipe box and I refer to it all the time. But if the recipe gets written wrong, if the mutation causes an error and, some part of the recipe gets deleted and you make too much or not enough, or if you substitute the wrong ingredient, it's all about that preciseness of the recipe. And any number of things, including smoking, can mess up that recipe. Next slide. So the best analogy for this, really, for biomarker testing is your check engine light. Like, I don't know how my car works. My husband loves to remind me of the time I asked him what the genie lamp meant because it was flashing at me. Like, that's where I am with cars. And that's how a lot of people are with all of this mess up here. It's really complicated stuff. But think about it like this. If your car doesn't start, it can be any number of things. It could be you're out of gas, the battery's unplugged, there's a number of things that could happen. When you take it to the mechanic doesn't just say, well, I'm going to change the battery. Like, they're going to do some tests. They're going to run that diagnostic test and they're going to figure out exactly what's wrong with your car. They're not going to assume it's the most obvious thing or like, oh, I'm going to change your oil. That didn't fix it. Now I'm going to do this. That didn't fix it. They're going to first look to see what's actually wrong with it before they start trying to fix it. That's what biomarker testing is. Because you can see all these different colors, it basically represents the order that the mutations happen in the cancer. Everybody's cancer is different. We're all unique in that way. We've done studies where we've looked at the pattern of the mutations that people's cancer have, and they are very different. It's not a one-size-fits-all approach when we treat people. But if we give people access to biomarker testing, what we're doing is we're doing that extra diagnostic workup before we get you started and put you on a treatment that's not likely to fix the actual problem. We can get you the right treatment right away. Next slide. Okay, so just to illustrate this from a personal experience, both my father and my uncle were diagnosed within months of each other with lung cancer. My dad got his low-dose CT reluctantly. He was kind of a brat about it, but I convinced him to go because he was a current smoker and didn't want the lecture. That was his rationale. They caused the most aggressive type of lung cancer at stage 1. And had he waited, had he put it off 6 months, it would not have been a good outcome. My uncle, on the other hand, he too was a smoker my whole life. Both of them were smokers. He had been having symptoms and hadn't told anybody about it for a really long time. And by the time he was diagnosed, he was stage 4. But, and this is actually one of the pathology reports that we had as a family, because we also, in addition to our lovely history of lung cancer and smoking-related cancers, we carry the BRCA mutation for breast cancer. And as carriers for that, this is the type of information they give you. And no normal person knows what any of this means, but this is literally what they hand you as you are walking out the door. And they're like, here's what it says. And they basically say, you're positive. Good luck interpreting what any of this gibberish means. Next slide. So when we're talking about he got that, when we get that test, that genetic test, but you also get a biomarker test, there are two different things that they're looking for. A genetic test, like the BRCA test or something, is going to tell you what you were born with. Like, were you born with a genetic predisposition to cancer? A biomarker test assumes you have cancer, and they're looking for what's wrong with that particular cancer. And so sometimes people think they've had biomarker testing when really they've had the genetic testing, or vice versa. So if you have a family history and you are concerned about that, be sure to mention that, even if it's lung cancer. Smoking runs in families too, but that genetic piece, he hadn't thought to mention he was a carrier for BRCA, but by knowing that, it opened up a lot more treatment options for him. So it is a combination of what's going on with your tumor, but also these other kind of personalized factors that could affect ultimately your treatment outcomes. Next slide. But this is where we stand with biomarker testing here in Missouri. We don't do a great job. For a lot of this reason, why we're not getting very high rates of biomarker testing is that not all insurance will cover it. Not everyone offers it. And sometimes not everybody's a candidate for biomarker testing if you have very late stage lung cancer. But even if you take that out of it, these rates are really low. We need to increase the amount of biomarker testing that's done across our state and do a better job at that, because it's like we're trying to fix cars without actually knowing what's wrong with them. Like, that doesn't make any logical sense. Next slide. So there is current legislation here before the Missouri Senate. So let's all, if you know someone in the advocacy world, this is the type of thing that goes under our radar. And most people see that and they're like, why do I care about that? There is this new legislation. It failed last year, but it's back on, and they're hoping to make it part of the law that insurance companies, including Medicaid, should cover biomarker testing for all patients. This is how we change and improve some of these inequities that we've been talking about. We need to make sure everybody gets this, because that's going to get you routed to the best care for you. Next slide. So you actually have some information, I believe, in the packet, but this is a really good report that was put out recently. And we actually use this to kind of frame some of the work that we do at the state. So they were basically trying to understand what's the ecosystem here in St. Louis and here in Missouri as a whole. How well are we doing in the lung cancer space? Where are some things that we can be doing better? And once this got published, our team, I'm part of the Missouri Cancer Consortium. We're a bunch of folks from all over the state who are trying to improve cancer care for people by fixing policies that are broken and fixing systems that are broken, by sharing ideas and trying to elevate people's concerns to the people who can actually change things. So once we got this information, our team really ran with it. Next slide. So this is the best way to get involved. If you are a lung cancer patient, if you are a caregiver, if you're just a concerned citizen, we have a new group that we've been pulling together over the last few years called the Missouri Lung Cancer Coalition. We have been working tirelessly to try to improve the state of lung cancer here in Missouri and basically trying to idea share. We've been trying to pull together, so we need to know what's not working for you. If something isn't working, tell us. we will chase it down. If you just need a support group, contact us. We will help you with that. One of the projects that we have that we are really hoping to get off the ground in the next 6 months here is a radon, is our work with radon, as everyone has been mentioning. We are planning to implement a library lending program where we can have these little snazzy things in the libraries and you can actually go rent it and pick it up and take it home. And yeah, that's how you fix things. And those things, I've priced them out. They are in my cart right now. You can get a cheaper version of that that's just as good based on the data for like $150. But if we can put a few of those in the libraries, we're going to start up near North County because I'm also super involved with all of the RICA work because that's a whole lot of craziness happening up there. And we know there are high radon levels up in that neighborhood. So we're going to start in some of our local libraries, but also reach out to folks down in the Boot Heel and, other parts of the state and start sharing these. But we want to not only have it to where you can check it out, but then once you get a positive result, what do you do about it? We're going to have a team pulled together to help you through the next steps. And actually, through our work with the coalition, we've actually have legislation pending for a radon bill in the Missouri House. And it has bipartisan support, which is amazing. No, you never get that. But in the state of Missouri currently, I have to have a license to cut your hair. I have to have a license to shave your dog. I don't have to have a license to mitigate radon in your house. I could claim I'm a radon mitigation specialist and there is no one to check. We're trying to fix that so that when you get a positive test and you give somebody $1,000 to fix your house, you can be sure that they know what they're doing and that they're actually qualified to do that they're not just selling you a batch of hooey and it's not actually going to work. So those are the types of things that we recognize the need as a team. And we're like, well, and it comes from the testimony of individuals who say, I got my home mitigated and the radon's still there. I got it retested. What the heck's going on? So we hear from people about things that are happening, and then we're trying to make a difference by changing the systems that are broken and just making these tests more accessible. But if you need a radon test, reach out to us. We are in pretty much weekly contact with the folks in Jeff City who actually distribute those tests, and we can find you a test. We will scour all of Missouri and find you a test if you need one. That's part of what we do is like we're problem solvers. We try to share ideas across the state and figure out who's got what and who can fix this issue. Next slide. So, this is really where, as the whole scheme of things, this is where we're hoping to get. Right now, if we can get people in for screenings, and we have a 92% accuracy on these screenings if we supplement them and get them these AI tools, we can catch people early. My uncle, even though he was stage 4, is still doing great because of biomarker testing, because of knowing exactly what's happening with his tumor. If we were thinking about like my grandma's situation, she was gone in less than a year. There was nothing that could be done. Here he is 4 years later. And he has all that extra time with his grandkids and with us. And the same with my dad that we missed out on because none of this was a thing back then. So much has changed in 20 years. So as we're looking at the roadmap, we need to think about, am I getting the best possible care? And is everyone getting the best possible care? Because it does us no good if we get these technologies and only people with really good insurance or a lot of money can afford them. That is not the solution we are looking for. I want to make sure everybody knows that this is a thing and has access to the technology. So, and ideally, we want to get to the point where we're starting to do more of these additional clinical trials. And that's where teams like our team at WashU, we're really involved in personalizing the whole process. We actually have a clinical trial going on looking at what type of smoking cessation works best for individuals based on your genetics. Because we know not everybody is successful at quitting smoking. And now we know some people are hardwired to respond to one treatment better than the other. other. But nobody does that test. They just give you the gum and say, good luck. But no, like, that doesn't work. So wouldn't it be great if you knew the gum's never going to work for you because you're genetically, it's not going to work. This is what's going to work for you based on what's tailored to you and your individual biology. So there are a lot of these awesome clinical trials that are going on, but we need more. Next slide. So here is my contact info. If anybody has any issues getting radon tests or getting access to anything related to lung cancer or really anything cancer related, I'm part of the program for the elimination of cancer disparities. So you may have heard us as PCAD around here locally. But our team is tasked with going out into the community and then relaying the messages we get from the community back to Siteman so we can do better and we can make sure that our research is matching what everybody in the community actually needs. I'm happy that finally, we are getting a mobile screening unit for lung cancer. It is coming out this fall, so we are super excited to be able to bring the screening to people. But now we're doing the work as to trying to get people to show up when we bring the van down there. We want to make sure people know what they're getting into and that it's not just screening, it's what happens if the screen is positive. We have to be ready to help those folks. And that's where the Missouri Lung Cancer Coalition is going to come in. We're going to be that part that helps get you to Julie or get you to the right navigator. Because honestly, I don't care where you go. All of our partners in the coalition are from fabulous hospital systems. I would trust any one of them. So I'm not necessarily trying to pull people just to my cancer center. I want them to just get screened anywhere. And that's, we have this link called getscreenednow.com. If you go to that and you type in your zip code, it will tell you every place nearby that offers different types of cancer screenings. Because we don't care where you go, just go somewhere. And if you are having any issues, contact us and we will get you the help that you need. Okay, well, thank you.
We're going to take a little bit of time for some Q&A, and I'm going to, first off, there was a question that came to us out of the ether, where your slides wound up. No, the question that came to us online was, what can healthcare systems do to improve community awareness of the lung cancer screening programs? Julie, we'll start with you on that one.
Hello. So education is what we can do. One of the things that we are looking at SSM is how can we get into the communities, every community, to offer this education. We're trying to get into churches, women's groups. There's a great organization that does prostate screenings and the demographics. So age is the same for screening. So can we tag on with them to help promote lung cancer screening? So if you know anyone, want somebody to come out and talk, I'm your woman. It's a great thing to do to be able to help. And
Sarah, do you have a comment you wanted to make on that one also, Sarah?
I know we work closely with folks at SLU. Like we are, when it comes to the cancer screenings, the St. Louis community is really united in that respect. Like all of the navigators from BJC and SSM, we're all together on these calls and trying to figure out who's going to go where. We do a lot with trying to go out into the community. Right now, the rest of my team, my other partners, they're down at Pride. We go to churches. We just finished an event at Hazelwood, educating young kids and high school kiddos about the risks of cancer and smoking. So, we try to be creative because cancer prevention happens before you walk in the door at Siteman. So we got to get you where you are, and that's out in the community. But yeah, churches have been great partners, the school districts. We have a good partnership with the VA health system too.
We was telling you to put that a little closer to your mouth, that's all.
but yeah, we're trying to also start some work with some of the local universities, like, the community colleges and that sort of thing. We go to farmers markets. We were at Point Fest talking about prostate cancer, a big concert. We're really creative with it. We try to be out and present in the community. So if you know of an organization, we can bring our Health on the Move van there and get all of this information right out into the community.
If anyone here has a question, please raise your hand and I'll come around to you. But while we're waiting, Dr. Punch and Dr. Flano, Dr. Punch, you mentioned something very interesting. Actually, it kind of reminded me of my cousin Vinny, where he talks about the dirty windows in this woman's house. That is second and third hand smoke you're talking about. How do we put that together with our risk for developing lung cancer? Explain also what secondary and tertiary risk factors for smoke is, and then put that together with the increased risk associated with radon, if you would.
So we know.
It's on.
Okay. So secondhand smoke, someone's smoking, they blow out, and whatever is left over from a burning cigarette and you inhale that, that's the secondhand smoke. Tertiary or third-hand smoking is what builds up on the windows and the carpets and the furniture, and that all of these other toxic chemicals and whatever else settle in, and you get that exposure. We see it a lot, especially with kids as they're crawling through the carpet, and then they grow up with, other lung diseases, asthma, sinus problems, stuff like that. But we do know that it does increase the risk or the likelihood of developing lung cancer if you live in a household of somebody that's smoking, as well as with all of the other chronic lung diseases that's there. The hard part is knowing exactly how much to quantitate it so we could start screening. Maybe later in the future we'll do that, but right now we do know that there's an increased risk of having lung diseases, lung cancer being one of them. And then
So Dr. Punch, put that together with, you mentioned about asbestos, but there's another thing from environmental pollutants, particulate matter. You talked about asbestos, but PM 2.5, these really fine sized things. Should we not also be taking this into account when we talk about environmental risk factors with lung cancer?
Yeah, anytime you are exposing your lung cavities, the little sacs of air, to things that create inflammation, you're creating an environment in which your cells are fighting all the time. Cells that are fighting all the time are at risk for having that one cell get the recipe wrong. So it is definitely an additive effect where the air we breathe and the inflammation is a risk factor, quite honestly, for a number of chronic diseases. And it is amazing with newer construction, your grandma's drafty windows actually in some ways are helpful because you're getting fresh air, but tight apartments that are got perfect windows or don't even have really windows that open up and everything is super, super insulated makes the quality of the air definitely can be less. So definitely we learned this in COVID. Building health is ventilation health, and that ventilation, air moving, should ideally also come with some level of filtration. There are ways you can find more about the quality of the air in any closed system, but I think the bottom line is that inflammation is definitely a hand-in-hand part of the risk for cancer, and the truth is there's many different ways that can show up. And there are ways that you can better assess, but the practice of thinking about ventilation in any closed space, whether it's opening a window or whatever, I think is actually more important than we can imagine.
Thank you very much. We have a question.
There are young smokers, as 12, 13, 14, marijuana, cigarettes, vaping. What about that age group for getting lung cancer and getting testing? Do they have to wait till they get it and they're older?
And also, Dr. Flano, would you comment about just the risk of lung cancer and marijuana smoking?
Yes. So the challenge with younger generation smoking and the risk factors are still there. The problem is we haven't really figured out where a lot of the screening will impact or how it's going to impact the biggest population. So when we screen, there's some limitation. CT scans are expensive and whatever else and stuff like that. And so they try to balance it on where you're going to get more bang for your buck so the price of healthcare doesn't go up in the U.S. Okay. That's why the age limits are a little bit set in that way, and then they adjust a lot of the other criteria so that we get the most out of the money. Who's more likely? The young ones, not as likely. However, the past few years, we've seen some changes, some shifts that we think these screening criteria are going to change. I don't think the one size screening fits all. I've had 29-year-old stage 4 cancer, 34-year-old recently. So these are things that we're looking at, we're following. Starting young, though, and the companies know this, they push that. You heard all the problems with the flavored vape pens and stuff like that, targeting younger kids because nicotine is extremely addictive. Right? More addictive, almost as addictive as cocaine and heroin. So it's that addictive. But you have a growing mind that's growing and it's incorporating these addictive substances into their brain's growth, and it's harder to quit. But when the kids run out of money for those vape pens and whatever else, they're going to go to cigarettes, and that's what they're counting on.
Would you tell us, when we talk about the risk of marijuana smoking, and just give us that number that is considered that puts us into the lifetime risk? What is that number?
Yeah. So we know that if people are heavy marijuana users, they have a twofold likelihood of developing lung cancer within their lifetime. And that heavy criteria means that you've used it at least 50 times in a lifetime. I didn't say a week, because we know some people, right? In a lifetime.
Thank you very much. Yes, sir.
I got a question. I'm born in the 60s now. Saying if you got all this stuff about cancer, now you got majority of the stuff, people who was born in the 60s or the 50s had like lead paint and other stuff on these like miracle spinning wheels and stuff like that these companies put out. What do you think about if a person was born that particular time, would he get a lung cancer or would she get a lung cancer?
Yeah. So I think a lot of those exposures do increase your likelihood of developing lung cancer. I think when you speak with your primary care physicians, you need to, let them know what you've been exposed to. For example, those that have been in the military and worked around the burn pits, we've seen that. My dad was in the military, 20 years, he got exposed to Agent Orange. He quit smoking 38 years before he was diagnosed with lung cancer. So it's things like that we'll start to find out more as we start looking more through us looking at clinical trials, using AI to abstract the data and compile the composite to figure out these risk factors. But when you speak with your primary care doctor, we need to let them know what you've been exposed to, because then we can determine risk factors. And just a quick example I throw out there. The Wizard of Oz, you got all the other stuff like the snow was asbestos flakes that everybody was on the site. Yeah.
Go ahead, Sarah. You want to come?
It's also important to know some of the occupation, like back in the 50s and 60s, or even up through the 70s and 80s, mechanics were regularly exposed to it because the brake pads contained asbestos. If you worked in HVAC, my grandfather was a veteran. That's probably where he got exposed, was the HVAC systems on a lot of the ships were just coated in asbestos for fire control. So it's important to know kind of what your possible exposures were. And a doctor's not always going to ask you, well, were you a mechanic? But that's relevant to your health. It's where you live and work. Like, that matters.
We're going to take a final comment from each one of our speakers. I'm going to tell you what I want you to say in 1 minute time. So, Doctor, going to start off with Dr. Punch. What is the best way I can decrease my risk for environmental toxins that can cause cancer?
The best way in St. Louis and North City in particular is to be aware of construction and demolition that's going on in your neighborhood. Consider getting access to at least a one-time spot screening of radon where you live, and recognize the impact that burning tobacco has in your life, even if it's not you doing it.
Okay, thank you. Dr. Flano, we heard a wonderful presentation about the role of AI and how it's going to help us as far as finding and following patients with lung cancer. Is it myth or reality?
I think it's a reality. We've been working with an AI system for the past 4 years to help us actually look at the lung tissue that we do in real time as we're taking a biopsy sample and tell us if we're in the right place or not. That's really helpful because we don't oversample and increase our risk of a procedure, and it helps us know that we have enough tissue to get the proper test we need.
Thank you very much. Julia, does the navigator call me or do I call them? And what is the best way to tell I'm being screwed?
It can be either way. Generally, if there's a navigator there, they're going to reach out to you. But let's say nobody's reached out. Ask when you're diagnosed, is there a navigator? Will she reach out? What can I do? I can also tell you that there are navigators associated, I think it's the American Cancer Society. So somebody can help you if your facility does not have one. Reach out, advocate, call me, call the,
I will figure it out.
tell me the group again.
Oh, the Lung Cancer Coalition.
All right.
Yes,
Sarah,
that's
since
going to be
you,
a great resource.
all right, Sarah. So my question is, I live in a house with people who smoke. We've heard all these grandmothers smoke. These people blaming grandmothers. I mean, come on. I mean, grandmas are good. What the guy said, grandma's hand, and all this. These people, talking bad about grandmas. But anyway, my grandmother smokes, my uncle smokes, my father smokes in the house. Everybody's in there smoking. I live near a coal mine, and so I'm getting all this radon that's coming up on me, and I'm 36 years old. I'm scared. Can I go and get screened for lung cancer?
Unfortunately, no. And this is where these systems need to change. So currently, the recommendations are very strict about who is eligible for screening. Even folks who, we have a lot of non-smokers who advocate with us on the radon team, who are lifelong non-smokers who have had radon exposure and developed lung cancer, and they were never eligible for lung cancer screenings. And that needs to change. So there are some rumblings that there may be some changes here soon, but I think the biggest thing is just being aware of it. And if you have any signs or symptoms or any reason to suspect that something is off, don't hesitate to reach out to your healthcare team. Don't trust your gut. If something feels off, you deserve to have it followed up on.
Let's give a hand to our panel. Thank you all very much. And y'all can step down now. You can step down. I want to bring up again Mr. Manhan Shaw to give us a word or two about something you may or may not heard about, something called 340B pricing. Don't get scared, but it's something that's very important in terms of how we're paying for health care for a lot of people. Mr. Shaw, thank you.
So I realize I'm in a very dangerous position of being between you and lunch, so I am going to be fast, but this is something very important that we need your help on. So I'm going to tell you what it is. I'm going to tell you why it's impacting you and what you can do about it. How many of you have heard of 340B before? How many of you have heard about 340B? Okay, excellent. So in your packets are 2 sheets about this issue. You can take it home. It's yours to keep. But let me talk to you about what this program is. Back in 1992, Congress created a program called 340B. The idea was very straightforward. Hospitals and clinics that serve low-income and underserved communities could buy prescription medication at a big discount. The rationale being that those savings could then be used for patients. So hospitals could use those savings towards things like lower drug costs, free or low-cost health screenings, transportation to appointments, extra services for people that were uninsured or couldn't afford care. That was the intent of the program. And for a very long time, it was a program that worked, and maybe you realize it or not, it could have benefited you, your family, your neighbors, and your community. Here's the problem. Since 1992 onwards, not every hospital or clinic has used the program the way it was intended. Instead of using that money from savings for the items that I just described, some hospitals bought real estate. They increased executive pay. They bought or signed expensive corporate contracts instead of helping patients like you. That's not right. It's harmful. And when people in this room are still struggling to afford medication for cancer, for heart disease, for diabetes, for other issues, we have to recognize what it is, which is just not right. So here in Missouri, there's actually something being done about it. This year, the legislature passed a bill called House Bill 2011. And all it's doing is asking for transparency. In plain terms, it requires any hospital, any health system that is using this 340B program to show where the money that they've saved is going. Think of it this way. If you gave someone money to buy groceries for your family, you would want to see the receipt. What did they spend that money on? What did they get? That's what is being asked of the state right now. 11 other states have already passed this legislation. Missouri would be simply joining them. So right now, this bill is sitting on Governor Kehoe's desk. He has less than 30 days to sign it into law. And so here's what we need from you. The most powerful thing that you can do is share your story. If you have struggled to afford your medications, if your medical bills have piled up, if you've had to unfortunately choose between your prescriptions or your groceries or your other bills, lawmakers need to hear from you, because real stories from real people in this state, their constituents, is what is going to make these politicians act. And so what we're asking is, if you are open to sharing your experiences, there's two ways that you can do it. You can either write it, and Gabrielle and Rachel will be happy to collect it, or our colleague Steve, the gentleman with the camera running back and forth, getting his steps in, has set up a mini studio outside in the hallway. So if you want to be mic'd up and if you want to share your story on camera, Steve will do a fantastic job of capturing it. Your story will not be shared or published without your permission. Full stop. So if you are open and interested in sharing your story, we'll capture it and we'll make sure that you ultimately decide, are you okay with us sharing it, passing it on to legislators, giving it to the governor's office, and making sure that your voice is heard. So that is our ask for you today. Thank you for being here. The fact sheets in your folders are a great starting point. You can take that entire folder back home with you. We're going to be here for a bit more. There's lunch, and I think Dr. Tuckson will provide final comments. Thank you.
Julia, the navigator, brought some information that's back here on the back table. I encourage you to please stop off and pick some up. Also, please ask our speakers if you have a question, something you didn't want to ask out. Be sure and ask them about this. There are drinks on the table here, but there's lunch just out there in the hallway. Carla, make sure before LJ leaves with your radon detector, you get it from, he's right here. Don't let him get out the room now, you know. Brother a little sneaky, so make sure now we get that done. Be sure to fill out the post survey that's in your packets. That's very important to us. That kind of gives us an idea if we're meeting your needs and hitting the targets that we want to hit. We really appreciate you who are here in person with us. For those of you online, thank you for joining us. I want to remind you that we will be available for streaming. You can go on Facebook and over to the HEAL website, and you can see this and the previous session that we had here in St. Louis. I think it was back in November or December. So please give yourselves a hand for being out here, and thank you very much. Lunch is out there in the back. Drinks are right there. Information about Navigator services also right there. Thank you very much.